everyone to the joint Kensington and Chelsea and Westminster Health and Wellbeing virtual meeting. The last meeting was hosted by Westminster, so I propose that I lead the discussions for this second virtual meeting. So I'm going to hand over to Tim, Councillor Mitchell, to see if so he can put this forward to his board.
Thank you. Could I ask the Westminster board members to approve the proposal that Councillor Addenbrooke chairs this meeting, unless I hear to the negative? No? Okay, thank you very much indeed. Over to you, Sarah.
Thank you. And I'd like to ask the Kensington and Chelsea board for their approval to this proposal. And I will take it that silence means yes. So just a little bit of housekeeping. So in line with government guidance that everyone should work from home as much as possible, this meeting is being held via Microsoft Teams, and all the committee members, council officers and the parties who wish to participate in this hearing are joining from remote locations. This event is also being streamed live on YouTube, and members of the public and the media are welcome to remotely follow the meeting and listen to the discussions taking place. The papers for this meeting are also available on the RBKC committee's webpage. I'd like to run through some important details regarding the Teams meeting, mainly that if everybody could put themselves on mute, obviously unless they're invited to speak, and also to turn off your video to save bandwidth. If for some reason I lose my internet connection, then Councillor Mitchell will step in to chair the meeting. And if anybody wants to speak or ask a question, could they please put a Q in the chat function? And I think that's it. So in March 2019, the Joint Board chose 3 health and wellbeing priorities: dementia, taking a public health approach to serious youth violence, and mental health and resilience. However, given the ongoing exceptional circumstances, the priority of this board meeting will be the second wave of the COVID pandemic. So we move on to apologies for absence. There are a number of apologies. So far I've got Dr. Neville Purcell, Councillor Josh Rendell, Bernie Flaherty, Robin Duran, Leslie Watts, Jennifer Travassos, D.I. Liam Adams, Anna Gapopsa, sorry, apologies, Hilary Nightingale. Does anybody have any other apologies for absence?
Sarah, could I give the apologies for Gareth Wall, please?
Thank you.
Thank you.
So does that mean, Andrew, you'll be presenting the dementia plan?
Yes.
Thank you. Okay. So item 3, declarations of interest. Does anybody have any declarations of interest?
I would like to again state that I work for an organisation called the...
Could you introduce yourself?
Hi, so I'm Councillor Butler Thalassis, and I just want to mention that in my day job I work for an organisation called the BME Health Forum, and because a lot of our work is about the health and well-being of BME communities, that could be seen as a conflict of interest with what I'll talk about later.
Okay, thank you. Do we have any other interest to declare? Now, are there any other matters arising? Does anybody have anything? Okay, thank you. So we move on to minutes of the last meeting. Can I ask the Kensington and Chelsea and Westminster boards for confirmation that the draft minutes of the joint meeting on the 9th of July 2020 are an accurate reflection of the meeting? Thank you. I'll take it that they're agreed. So before I invite Russell Stiles to present a verbal update on COVID-19, Councillor Mitchell and I would like to take this opportunity to thank our partners around the table for your excellent collaborative work over the past few months in responding to the ongoing COVID-19 pandemic. Russell, would you like to now present your paper, or your verbal update, sorry?
Thank you, Councillor Addenbrooke. I believe some slides will come up. Thank you. So next slide, please. So the current status, this is based on epidemiology as of the 8th of October. Both RBKC and Westminster have a COVID-19 case incident rate that exceeds 50 per 100,000 today. And that's the first time that this has happened since the first wave. RBKC is 58.9 with 7.7% positivity, and Westminster is 57.2 with 7.6% positivity. This compares to London, which is 66.6, 7% positive across the capital, and England is now over 100. It's 109.3 with 10.2% positivity. So that basically translates to every 1 in 10 people in England who have been tested for COVID are positive. Local modelling indicates both RBKC and Westminster will exceed a rate of 50 for the foreseeable future. And both golds, RBKC Gold and Westminster Gold, are convening this afternoon where the local response are being prepared. Sorry, I think the slides dropped in terms of the next slide, please. So this, thank you. This shows the testing and contact tracing. So if you look in the top right-hand corner, you can see how the proportion of positive tests have changed since early September. It was plateauing from mid-August to mid-September, but in recent days it has increased sharply. Again, in terms of the rate, it's quite hard to discern on this slide, but in the middle, it shows the steep rise, middle top, to 57.2% today from the 22nd of September. So quite a steep upward trajectory. Top left-hand corner of the slide are the number of cases per every 7 days on average. So Westminster has 20.9 cases per day over 7 days to the 2nd of October. Middle left of the slide just shows how cases are proportioned out across the wards, and there's quite an even spread, and that situation does fluctuate. Next slide, please. So again, this is RBKC. It's a very similar pattern. Top middle, the rates increased sharply to 58.9. Top right hand side, you can see the positivity has increased sharply from up to 7.7%. And again, the cases are spread quite evenly across the various wards. And on average, there are 13 cases every day coming through. There is a lower population denominator for that to take into account. Next slide, please. So this is the rates per 100,000 as of today across the capital. Going back 3 or 4 weeks, we would have seen lots of the boroughs would have been green in that the rates were below 25 per 100,000. Sutton is best placed in terms of incidents today at 35.7 in the south, but the rest of London, apart Merton's just above that, but most of London is now red, and Richmond, for example, over in southwest London is 94.5, and then Hackney is 94.4, and Redbridge is 97.4, so just over 100 under 100 per 100,000 cases in Redbridge. So in terms of East London was leading the way in terms of COVID-19, but you can see from this graph how the virus is now spreading across the city, and there is quite sustained community transmission. So I'll stop there for any questions, Councillor Addenbrooke. Thank you.
Thank you, Russell. Does anybody have any questions? Olivia.
Thank you, Councillor. Obviously, we welcome a very helpful and informative response. I would just like to flag that you have a local health watch here who's been collecting consistently experiences of local people through the pandemic, which we were able to share at the last Health and Wellbeing Board. So I would encourage you, please do get in touch with us. We're only tiny, but we're collecting some valuable information and are doing workshops with different communities and such like. So I really would want to flag that. I note your sort of intentions to have health champions. That sounds a great idea. Again, I'm sure members and, for example, our dignity champions at Healthwatch would be keen to participate. Our young Healthwatch have already, working with the Mosaic Trust, Community Trust, does work with young people around no longer being passive recipients in terms of test and trace, but being proactive. So that might help and contribute to some of your thinking there. But I think it's a little bit frustrating, and we are keen to work with you and support. And I had hoped that the data and evidence that we'd shared at the last committee would have helped you to pick up and connect to us. So it's just a plea to not add to our workload, but make use of this evidence that we're collecting. Thank you.
Thank you. Absolutely. We'll be in touch.
Thank you. I'm just reading in the chat. Ulash has said there is talk that the Prime Minister is going to announce further lockdown measures on Monday. Is there any background or intelligence on this?
So in terms of the media and the kind of rumour mill, as I understand it, there's a plan that's being discussed that has a kind of 3-stage approach nationally that will inform policy imminently, I understand. So that is being discussed. In terms of any kind of lockdown, it's very likely to be on a regional basis, and I think that once London gets to a rate of 100 per 100,000, then there'll be wider discussions in terms of advice. So the advice it would be very likely nothing but essential travel, for example, which will come in from next week. But in terms of sort of wider lockdown measures, I'm not privy to any information on that.
Thank you. Ian, do you want to ask your question, or do you want me to just read it out?
Matt, 6 or 1. I'm happy for you to read it. That's fine.
Okay. So Ian's asking, is there a trend in terms of age groups testing positive? And also, I'd just like to ask, are we seeing an increase in hospital admissions?
So in terms of age groups testing positive, most of those who are testing positive at the moment are still in that, is in the younger adult working age, so 18 to 40 predominantly, and from that the 18 to 30-year-olds. So they make up the far greater proportion of those who are testing positive. But we are starting to see very early signs of the virus spreading into other age groups. In terms of, but not in the same way that it is currently with young adults as a proportion. In terms of, there is a slight uptick in hospital admissions. Nothing in terms of what's been observed in northwest England and northeast England for London yet, but then of course the hospital admissions normally lag behind a sharp increase in incidence by 2 to 3 weeks. I can say in terms of just a general response, we're ensuring that the local community has a better testing offer. We're building in additional support and resources within council. So, for example, with contact tracing, we're ramping up our communication messaging. We're stepping up the kind of mortality planning again, as we did in the first wave, and we're looking at things like reviewing licenses for events, and we're preparing in terms of wider support for shielded residents. Happy to have any more questions.
Sorry, I've just been talking to myself. No wonder you didn't hear my question. Jenny Greenfield has put in the chat, is there any evidence of spikes linked to particular areas or places?
So we have outbreaks, ongoing outbreaks. So there are 20 to 25 outbreaks across the two boroughs combined, the cumulative total. I can't really give too much information in terms of where they are, but by settings we have outbreaks linked to schools, to universities, to restaurants. So it is quite widespread in terms of the number of live outbreaks that we're dealing with. In terms of the epidemiology, it's not particularly clustered to one neighbourhood, as I showed in the slide. It's pretty spread out across all of the wards, but there are outbreaks situations, and those that we're aware of are currently contained.
Okay, thank you. Okay, I think, should we move on to the next paper? Thank you, Russell.
Thank you.
So, Sarah, would you like to come and present an update on health disparities during COVID-19?
Thank you, Chair. I'll turn my video on briefly and then turn it off again just to say hello to everybody. It's a strange world that we live in, so probably helpful to have a face to the voice. But I'm going to give a quick overview of the report that I've put forward. There are three main elements, I think, for discussion. What I wanted to summarise very quickly was a little about the approach to date, what we've done so far and what else we plan to do to understand the impacts of COVID on our residents. The second thing was outlining some very early headline findings on those impacts, where it points to the need for action, and in particular what we've done already, some of which Russell's just touched upon. And then the final thing is just to have a brief discussion. Really, it was flagging that this work is going on, but to discuss ideas for how it can usefully support system-wide action on health inequalities, and particularly picking up on Olivia, what you said, and I'm sure many others have insights about the impacts of COVID. So it's drawing that together, understanding where that work is going on and trying to piece it all together, I think, is the objective. So if that's okay, I will launch into a quick summary of the approach to date. So what we've done so far is a rapid review of the direct and indirect impacts of COVID on our residents. We are working with academic partners. What we want to do is validate the data that we've used and to build a fuller picture, and that very much directs action. It shouldn't just be an interesting report. It's very much about what should we do about it. What we've done so far is to cut the data in lots of different ways. So we've done it by protected characteristics, by health conditions and behaviours, and factors like housing and employment, which we know is really integrally important to health and wellbeing. It's fair to say the data isn't brilliant in all areas. There are gaps, and so we do want to fill those. And of course, people don't fit in neat boxes. There is a complex interplay between the factors. So just looking at, for example, infection rates and deaths data in BAME groups doesn't tell us enough. We have to look at the housing picture, the jobs, the underlying health conditions to understand where the opportunities for action lie. And that's why this work really needs to be system-wide. Headline findings. So national data was presented at a previous board, so I won't recap on that. There is more detail in the report itself, so I'm not going to to delve too much into the detail, but in short, the local data that's emerging backs up the national findings, and academic partners that we've got on board will formally validate this in a report coming forward. I guess what I wanted to emphasise that, yes, the data that we've been hearing about COVID-19 impact is shocking and a call to action in terms of the disproportionate impacts, but it is one disease of many that affects people according to their existing health, along with the circumstances in which they live and work and they socialise and be with their communities. There are many other diseases which follow a social gradient like this, which is why we do have a life expectancy gap for men and women in both boroughs, depending upon the circumstances in which people live. So as an example, for men in Westminster, it's 13.5 years, and for men in RBKC, 14.5 years. I guess COVID has really shone a light on those wider disparities, and this is our opportunity to narrow the gap. And those cities who have established themselves as marmot cities, implementing the 5 recommendations from his 2010 report, are probably doing really well in terms of the sort of strategic areas that need to be focused on in order to address those wider health inequalities. So just moving into the local headline findings. So in terms of infections and deaths, like national data, local data does indicate that certain groups have been disproportionately impacted. So we know older people, men, BAME groups, people with coexisting conditions, and people living in deprived areas of our borough have been disproportionately impacted. In some cases, so for example, looking at the deprivation data, it indicates that COVID isn't necessarily exacerbating those differences, but they are part of the sort of health outcomes that we're aware of anyway that are stratified in that way. In terms of the indirect impacts, the emerging data seems to indicate that there are some key areas which we could focus on very usefully. They've been summarised in the paper as threefold, but undoubtedly they're not going to be the only ones. So it's action on the social determinants of health, mental health, and then targeted action with particular groups, with particular reference to BAME groups. Just taking each of those very briefly in turn, the action on the social determinants of health. So this is in line with what Marmot would suggest. It's housing, it's education, it's employment, it's environments. All of those actually have the biggest impact on our health. We know that there's been a large rise in universal credit claimants and uptake of the furlough scheme nationally. We predict that homelessness will increase, and we are seeing large numbers, a rise in numbers to the street in Westminster particularly. There has been a huge amount done, I think, to protect particular groups, for example, the homeless across both boroughs throughout Wave 1, and that work continues in earnest. I suppose there's also the flu jab, so there's again a lot of partnership working going on to make sure that we're doing all we can to protect people from the coexisting risk. And then there's a big relationship between things like work and other priorities that I've talked about, so particularly mental health. We know poor mental health is a barrier to getting into and keeping work, and that poor quality work can be a driver of poor mental health. So that really brings on to the second area of key focus. We knew already in our boroughs that we're slightly below average when compared to the England average for the numbers of people with common mental health disorders and severe mental illness. We know that people report higher levels of quality of life in more affluent parts of our borough. The insights that we're getting around COVID are that people have highlighted mental health concerns, particularly isolation and loneliness, anxiety and stress, and bereavement. And we think, looking at the local data and the national data that's emerging on this topic, that young adults, women, people with lower education or income, people living alone, and adults with long-term conditions or disabilities and their carers will be particularly important to target in terms of improved sort of mental health resilience and support. And it will be very interesting to see as time goes on how access to mental health services has been affected by lockdown and COVID in general. And obviously we think it's a key area of our work that we will continue to monitor those sorts of indicators. So just coming on to the final area of action outlined in the report, which was targeted out at action with particular groups to prevent COVID and also to improve other outcomes. I mentioned BAME groups. We have commissioned work by an enterprise, social enterprise called Support When It Matters, or SWIM. And that research with ethnic minority groups in North Westminster found, for example, out of the 312 people participating, that only 44% would use track and trace, and 62% would be reluctant to vaccinate if there was a COVID vaccine. We know from the local insights that are feeding back to us from our community champions that there's great concern and reluctance to take up the flu vaccine amongst those groups. So there are lots of recommendations in the report that we've received from SWIM, which is relevant across both boroughs, including how to motivate participation in test and trace, how we would reduce reluctance to be vaccinated, and opportunities to improve other health outcomes such as diabetes and smoking cessation. So lots of really, really positive things that we can do, some of which Russell's touched upon already, and there's definitely more work that we are investing in there to improve outcomes for BAME communities in both boroughs. There are we've got, I talked about health champions that we've got. So, for example, we've got 69 health champions in Westminster. We've got community champions trained across both boroughs in 11 distinct patches who've been supporting COVID messaging and giving practical support like food distribution and signposting to mental health support. I think continuing that work and enhancing it through increased sort of COVID guidance and outreach work is going to be vital going forward. And I haven't mentioned it, but in terms of targeted group, obviously children and young people, this is across the life course. COVID has affected people in different ways, but everything that I've said applies to all age groups, and particularly thinking about groups of children where they're living in families that might have been affected in a number of different ways. So that's a very a whistle-stop tour of a very complicated and complex picture. It is, as I said, just the start of what we want to understand about the impact of COVID. We are seeing a rise in infection rates, as Russell mentioned, and a lot of our focus is on responding to that. But I think it's also important to look to the medium and long term and continue to monitor what needs are emerging, what might be new, and what is exacerbating existing need, and how we can all work together to address that. So in terms of next steps, the full report of the impact of COVID and recommendations for action to address health inequality is a sort of a desired objective going forward, and that's why we're working with local academic partners. There is recovery programmes in both councils trying to take forward action and target investment in areas of priority need. But I suppose the questions that I just wanted to pose to the board and open for questions or discussions is how we use this data we have and are collecting to usefully inform system-wide action, and how we can work together effectively to make sure this is a really good picture of need in our boroughs. And I'll leave it there.
Thank you, Sarah. There's quite a lot of things in the chat here. Nafsika, I think you had a question on this paper.
Yes, thank you very much. And thank you for a very interesting paper and the report. I felt that the part of the report that dealt with actions focused very much on ways of improving information for BAME communities. But besides that, there haven't been that many actions specifically to support BME communities. I think that if we look also at the next paper on the agenda, there is such a need to do something about the uptake in BME communities around flu vaccination. There's also so much that we could do in partnership with our NHS partners around diabetes. And I just think that these are really urgent things that need to be done immediately as we're into the second surge. And therefore, while it's great to do all the research and the work with the academic partners, we very much know that these are really strong areas of need, and that something should be done about it immediately. Thank you.
Thank you. Sarah, do you want to?
On that? Thank you. I really value those comments, and I agree with you. Time is of the essence. What we're doing is sort of doing the research alongside our actions. The actions regarding outcomes that we want to achieve with BAME groups. It's very broad what's in the paper, and I wanted to make it brief to show work in progress, really, rather than presenting a full list of actions that weren't reflective of all the work going on across the system. I think improving the cardiovascular health of BAME residents is vitally important. You talked about flu uptake, and that is something that we are working in partnership to address to combat some of the misinformation that's being disseminated. I think we're working on a full action plan on BAME groups, which isn't reflective of the two outcomes mentioned in the report itself, but it covers these are sort of areas of work that would require additional investment. So, for example, targeting commissioned sort of health checks for BAME groups. But there is a whole range of actions that we could take here and now that don't necessarily cost money. It's more about targeting our actions. So yes, we will be taking that forward, but I'd love to speak to you more about the work that you're doing and how we can work together on that.
Thank you, Sarah.
Just want to say, thank you very much. And I think one of the things that is really needed is also good data in terms of from my NHS partners in terms of how many, for example, of people in BME communities are getting vaccinated, how many are having their health checks, and as I said, in terms of diabetes, how many are coming for their health checks once a year, etc. So that would be very useful. Thank you.
Yeah, we have got that information on health checks, for example, but we are looking to make sure that all of our services we're reviewing them all to make sure that they are targeting the right groups as we would expect and achieving the right outcomes.
Thanks.
Thank you.
Thank you. I know Olivia has put quite a lot of comments in the chat, so I think I'm going to ask officers to take note and to get in contact with Olivia. Has anybody else got any questions on this paper? No? Okay, so we move on to item 6, and I'd like to invite Jo Olson, the Accountable Officer for North West London Integrated Care System, to give us an update on the latest developments within the ICS.
Thank you very much. Just to confirm, I'm the Accountable Officer for the 8 North West London CCGs, but I'm part of the ICS and executive, and I'm very happy to present the report. I was just going to sort of whiz through some key points. So if we could move on to, does the slide deck go up? I don't need it to. I can just say the key points if that would be helpful. I'll take your steer. Basically the points, the report in front of you gives you an overview as where we are in terms of the purpose of the integrated care system and our governance and what we're trying to achieve. It also tells you who the chair is, Penny Dash, who started on the 1st of September. Leslie Watts, I think you already know, as Chief Executive of Chelsea and Westminster Hospital Trust, and is also the Chief Executive for the ICS. We have also developed governance over recent months, and I would draw your attention to the top groups in terms of the meeting of chairs across boards and including local authority leaders. We then also have the partnership board, which includes a DAS, a DPH, and a local authority chief exec, and then we have the local authority leaders and NHS group. There are other places where local authorities are part of that too. It isn't all about at a North West London level. We are also very keen and are developing our borough-based relationships. And we have, I know I've spoken to some of you about the single CCG in other occasions and have talked about what we have at a borough level in terms of leadership, and are describing that as a quartet of both local authority, mental health, community and primary care lead. We've already touched on, I think you called it disparities, we tend to call it reducing health inequalities. We have a board that is jointly chaired with a local authority chief exec and a trust chief exec within North West London. And we are very much focusing on 3 areas of work: developing and supporting a culture that uses population health to drive change in service provision, developing employment opportunities so we don't exacerbate inequalities, and finally ensuring a system-wide accountability of delivery and assurance, which is jointly chaired with Bernie, who you will know. We have then focused on 4 areas around service update. One of them is the planned or elective care or planned surgery work stream. People may be aware that during the first wave of COVID, we stood down a number of services, including planned surgery, unless it was saving life or limb. As a result of that, waiting lists did increase considerably, and we now have the task of both having resumed surgery and also clearing that backlog. And in order to clear that backlog, there's a number of steps we've taken. One of them is using our theatre capacity much more. Secondly is the use of the independent sector. And finally, establishing something that's called fast-track surgical hubs. That is basically where you can do high volume activity and low acuity or sort of more simple surgery. And there is a map in the pack that describes where those are. This is work in progress. Some of those, basically, there is a lead provider for some of those services and where they're located. But the principle is your team follows you to the centre to do your surgery. If a patient doesn't want to go to, for example, Central Middlesex or to West Middlesex, they can choose not to do so, but may have to wait a little bit longer. We have also plans for restoring outpatients and diagnostics. The plan was that for outpatients, they have to be at 100% by the end of September. I think we're pretty nearly there. I know it's early October now, but the way we have also delivered outpatients is different in that we will continue to use, where it is appropriate, the sort of telephone or video consultation. And we have Andrew here from Chair from West London, who's been very much involved in advice and guidance to GPs, which enables GPs to continue to be able to manage patients. Diagnostics was something that was particularly challenging, where waiting lists have grown, but we're beginning to make progress. In terms of urgent care, we have worked over recent weeks, increasing the capacity in 111, and also to have greater capability within 111 to be able to do clinical assessments over the phone, so that you don't need to go to A&E. We are keen to keep the number of people down going to A&E and into urgent treatment centres because of the social distancing, and it probably is more appropriate anyway. We are piloting in Chelsea and Westminster, when people do call 111 and need to be seen, that they can be booked into the emergency department, so that we keep the numbers of people in the emergency department down to a number that is safe during COVID times. I know that local authorities and ourselves have been very concerned about support to care homes. We have continued to provide clinical support and will be ready for additional support, as you would have seen in the first item, as the rise in COVID continues. And while it is in a younger population at this point, we will expect there will be greater community transmission to older age groups as, unfortunately, the wave progresses. Just to confirm, we are, and I know Chanel is on the meeting, we have Pillar 2 capacity has increased. I expect we'll come back to testing, but just to assure you, in terms of people who are discharged from hospital to a care home or a domiciliary package, they are tested prior to discharge. So in terms of mental health, we have had talking therapies have reopened. Some of that continued during COVID with telephone and online consultations, but those have fully opened. One of the colleagues talked this afternoon about the importance of flu vaccination or immunisation. We absolutely recognise that. And to answer the question that she raised earlier, we have something called a, don't want to get too technical about it, but every week we have an update on what the uptake has been in terms of vulnerable groups. And again, Andrew may be better able to talk about this than me. We also have something called the Whole System Integrated Care Dashboard. So that identifies people who are particularly vulnerable and high risk. And so we'll have things on it such as ethnicity. We have targeted at the beginning. I mean, so all our plans are in place. We may be a little constrained by the supply of vaccine. So we have received the vaccine for the over 65s. I think we are waiting for this month for the vulnerable people over 50 and between 50 and 65 who have got, say, like asthma or diabetes, who may should receive a flu immunisation, and other groups. And then once we have completed those, we will then move on to people of the age group of 50 to 64, sorry, that is November, who do not have a higher risk. We have worked with colleagues in local authorities about how can we perhaps make a higher uptake in services this year, particularly people who may be at higher risk. So having a flu jab won't stop you getting COVID, but it might, it enables, if you do have an upper respiratory infection, it could help to be able to quickly diagnose whether it's COVID or flu. It would cut down, and it would also help the NHS. I do also want to assure you, I'm now on slide 20 of the pack, that we have been working very hard over the last 3 or 4 weeks, testing our plans to be able to respond again to a second wave of COVID. We don't know in what form that it will take, but we would expect an increase in cases. We would expect an increase in hospital admissions and those to ITU, but so we are basically assuming it may, or planning, that it will follow a similar sharp rise as it did last time. So as your colleague said earlier in the meeting, with the data that we get from testing, we are perhaps seeing what we weren't able to see in January and February of this year. And although we would hope that it wouldn't go to the same heights as it did in March, April earlier this year, we will be ready for that. And we have tested our primary care plans and other plans. I think you're familiar with the COVID thresholds and the escalation. We have, you were talking about, has there been a rise in admissions? We monitor those on a daily basis. And then the slide finally ends with what the public can do. I'll pause there. Thank you very much.
Thank you, Jo. Tanya, you've got a number of questions in the chat. Do you want to ask them?
Yes, please. In the Westminster report, there was a discussion or a presentation saying that by October, all trusts were expected to be operating at 90% capacity, but you can't undertake the same level of surgery. So what does this mean for the number of postponed operations and how long patients will have to wait? And how are you communicating this to patients to manage their expectation and manage the fallout from those who have deferred surgeries? Thank you.
Okay, thank you very much. So at the beginning of us planning for this, we thought it was going to be extremely challenging to recover because of the infection and prevention control advice that we had received in terms of having COVID-free areas. We have now, as we learn more about the disease and how we use PPE and prepare people for surgery, we actually have much greater capacity than we thought we would have. And so, although it's not my area, I have spoken to Rob Hodgkiss, who's leading the elective care programme. And he has told me that both Imperial and Shell West, although it is very challenging, are back up to the targets that we expected. In terms of the backlog, you will have seen from the data in this, which is an overall figure for North West London, the size of the waiting lists have grown, and particularly those over 52 weeks. We have detailed plans. I'm afraid I don't have them here, but certainly can provide them after the meeting in terms of what the plan is, in terms of how many months it will take to get there. But to give you an idea in respect of, because it tends to be lower priority cases of patients who are waiting over 52 weeks, we currently have 3,700. And we will get to 2,000, reduce that to 2,800. So although it's a reduction, it's not an elimination. What we will try and do during the next wave or successive waves is to continue the elective surgery during a COVID outbreak and not stop it apart from the absolutely essential ones. In getting to your point around patients, all people on waiting lists have been reviewed and they have been put in to ensure that they are in the right priority order. And we have worked through the waiting list in respect of greatest priority in terms of impact for the patient. I appreciate anyone waiting for surgery. It's an impact for them if they're having to wait a long time. Actually, one of the challenges, and this is why it's important that it is a clinician who speaks to patients, is actually persuading people to come in for their surgery. And as the COVID infection rate has gone up, the reluctance to come in has increased. I think in terms of your detailed questions around average waiting times or how we measure it, I think I can provide that afterwards, if that would be all right.
That would be helpful, but I just want to pick up on two quick issues. Do you actually have numbers of patients who have actually declined to come in for a surgery after they've been waiting 52 weeks? I'd be curious to actually, you have those numbers. That would be interesting to see, because that would conflict with what we're hearing sort of on the ground. The second thing is that you said that there are 3,700 patients who at this point are having to wait more than 52 weeks. Is that correct?
That's correct. It's in the pack.
Okay, sorry, I missed that number.
And also, I should say it's not just, some of it's surgery. So it says in the pack, it's 2,400. It's on slide, sorry, I don't have a slide number on my iPad. It says 2,400 are waiting for surgery. The 52 weeks can also include people waiting for a diagnostic, so a test or an outpatient. Just to clarify, in terms of where people have refused to come in, we've had a number of refusals to come in. I would have to check if they are off 52-week waits, but it is often the case that when someone has been waiting a long time and they are then offered an appointment, they may wish to continue to defer it. But we can provide that information.
That would be helpful. Thank you.
Thank you, Jo. Now, I think, Olivia, if you could put the queue in the chat, because I can't always see who's got their hands up. So, Olivia, I think you want to ask a question.
Thanks, Chair. Yeah, and thank you for Tanya for bringing that point around the detail on numbers. I would refer Jo to the London deliberative dialogue work that's been done and published recently. I'm sure that would help inform some of the reasons as to why people are reluctant, how valuable it is to listen to people's experiences to inform policy and decision making. Chair, my question specifically refers to slide 5. Is it possible to pull that up? And the structure of the ICS that's proposed. I'm afraid Healthwatch are really disappointed with that. I think it would help all of us if it's possible to see that slide. I think it's the structure one. Evidently not. Okay, so for those of you who have had a chance to look at it, there is no Healthwatch presence in that structure. The structure seems to be going backwards and forwards. I've had reassurances that the Healthwatch role is going to be integral to the integrated care system as per requirements and assurances under the Health and Social Care Act. But I'm very disappointed that we're not seeing that reflected. And some of those conversations I've had with Juliet Brown and with the meeting we had with other Healthwatches for North West London. So we're at a point now where we're referring this to Healthwatch England because we are dismayed and disappointed that the statutory duties and responsibilities of local Healthwatches are not being considered, and this is not happening in other parts of the country. So I think we really do need to take a breath and make sure that you have that. It's great to see some acknowledgement for community organisations, but that isn't the same. They can be providers of services, and it is not the statutory local Healthwatch provision that's seen in there. There was an excellent version that Andrew McCall had done from Central London, the chair of the Primary Care Committee, and I don't know whether you're still having dialogue on that and there's an opportunity for these changes, or what quite the challenges are to your structure. Be interested to hear on that. Thank you.
So thank you, Olivia. Just to confirm, in terms of one, it's an evolving structure in terms of we are developing this. It's not complete. I will follow up with ICS executive colleagues in terms of Healthwatch inclusion, and we'll pick up the discussion you've had with Juliet. And then secondly, just to confirm, in terms of statutory bodies, of course, we do continue with our Healthwatch engagement, and inclusion in that. But I appreciate your point is to seek inclusion in terms of the ICS governance.
Thank you, Jo. I know Nafsika has another question. Does anybody else want to ask a question on this? Nafsika, over to you.
Thank you very much. I wanted to again make the point that a paper that deals on health inequalities, and again in relation to COVID, I was hoping that we would see something more about BME communities and what the NHS is doing to ensure that that BME communities are thought of perhaps in another way as a vulnerable group, and to ensure things I've mentioned before, like in terms of diabetes, in terms of flu vaccination, that they're a group that we are working together to make sure that they're in the best possible health to deal with the second surge. I was also wondering about the escalation tables, because we've heard that we are now in the over 50 level, which is right at the bottom of the table, but I don't see any of the actions that go across that actually happening. So I was wondering why that is.
Thank you. I'll pick up both those points. Sorry, I forgot to say this as I went through the pack. In terms of primary care provision, in terms of the clinical CCG chairs and other colleagues, we took on board what were the most high risk factors in terms of having a poorer outcome if you contract COVID. And on that basis, we identified such areas as you have said, diabetes, hypertension, in terms of things that we could be asking practices particularly to be doing in coming months to ensure that we were trying to support and target, and including flu immunisation, to support patients to try and mitigate any immediate impacts of a further resurgence. So that is a plan, or it is what we have developed as priorities for our primary care networks to deal with. Certainly in terms of our staff who may be from a BAME community, every member of staff has had an individual risk assessment, and that risk assessment has ensured, because indeed many health professionals suffered illness as a result of the last large COVID outbreak, and we are ensuring that they are in safe areas to work going forward. So those are immediate things we did. In terms of the response around there isn't the over 50, that slide was about local actions. And I think, as your colleague said at the beginning of the meeting, when going through the COVID, where we are at this point, we move into London-wide and national actions. And so we reviewed earlier this week what further actions we could be taking. And I think the conclusion was we have done all we can at this point. It will require a London national decision around what further restrictions may be put in place next week.
Thank you very much. It's very good to hear that you said that these priorities have been identified in relation with primary care. Could you just give us a little bit of detail about what is actually happening as a result of these priorities?
So I wonder if Andrew might want to comment as a GP in terms of things that we have got PCNs focusing on in terms of hypertension and diabetes management. Did I see Andrew was on the call?
Yes, no, I'm here.
Thank you.
Yeah, no, Joe, you've given a very comprehensive explanation of what's going on. Yeah, we have various ways of identifying people at risk during the winter. We've got the WISIC tool, which helps us to do that too. So this helps us to identify patients who might benefit from having specific care plans or their care reviewed so that we can optimize their diabetic and hypertension control. We've had regular educational updates to GPs across Northwest London, but started by GPs here in West London, whereby we've highlighted exactly what particular risks these groups might have, and what interventions or additional care needs to be offered for them. And that's something that's updated regularly depending on how the guidelines have changed during the first peak and now in preparation for the second surge. So basically it's identifying the populations at risk for various reasons, which include BME and long-term conditions, then reviewing their care plans and optimizing their management. Does that answer the question?
It does. Thank you very much.
No problem.
Thank you, Andrew. Thank you, Joe. Does anybody else have any other questions on this? Okay, then I think we'll move on to item 7. And I think, Chanel, you're going to present this with Jane Wheeler and Dan Hurd. It's the joint winter pressure plans for the coming winter. I can see you, Jane, but I can't see the others.
Dan was never going to be here today.
Oh, wasn't he? Okay,
he's unwell. He's.
I'm so sorry.
But I thought Chanel was going to kick this off, so I was just.
I'm so sorry. I've been talking to myself.
Oh, okay.
Everyone. So yes, thank you very much, Sarah. This is, as you said, this is a joint paper, and we'll be jointly presenting it between our health colleagues and myself. So this paper summarises the winter programme across health and social care system. It is a currently it's a draft paper, and the reason why it is draft is because it's evolving and changing, and as we go deeper into the winter and experience surges and potentially second or further waves, the plan will change to address the priorities, and we will focus our resources to the areas to meet demand. So far, we have shared our plan with local A&E boards, and I'm pleased to say that it was received very positively. You will note that the winter plan builds on the learning from COVID pandemic and also from the previous winter programme, which was a successful programme last year. So this year, for the first time, Department of Health and Social Care issued a social care winter plan, which gives us a list of directions on where we should be focusing our attention and investments. Therefore, this plan also incorporates those expectations. So the board is asked to note the draft winter plan in its current format. It's a system plan, and our response to winter also managed COVID-19 pressures and risks alongside seasonal flu and other health and care pressures. So we understand that during this period, our residents and patients will be at risk, as well as our workforce, both health and social care. So therefore, the plan is also designed to respond to these pressures. So finally, the plan has two broad priorities. First is to manage people in the community to avoid unnecessary admissions to hospital. And second, if our residents are admitted to hospital and they need hospital care, to ensure that we have systems in place to discharge them in a timely and safe manner. So further updates will be available for the future board, but now I will hand over to either Louise or Jane for more details.
So if I make a start, if that would be helpful, I'm Louise Proctor from West London CCG. And I would just want to echo that I think in pulling this draft paper together, it's very much been about joint working between health and our colleagues across local authorities and a much wider group of providers, some who are on the call today and may be able to contribute to sort of bring it to life if that is helpful. In terms of the areas of focus, so really building on those two key themes that Chanel has just shared. We have a range of focus that's very much from within the hospital, and I suppose if I can pick a few of the sections up under section 3.5. So same day emergency care, SDEG. I'm afraid this is a new shorthand that people may start to hear a bit within healthcare, but the importance actually that we sometimes organise our healthcare a bit differently, so that people who may be residents who need support and some diagnostics can actually have access care on the day without having to be admitted unless that's needed. So actually, have we got our care organised that we can support people to get back home if actually they needed a diagnostic assessment in an acute way, but actually be supported to come back home if that's actually the best health outcome and the best support for them. The 7-day working being absolutely critical about hospital discharge teams, again, between our colleagues in the community services, local authority and the hospital really working effectively together. There's a range of support around mental health, investment and support around first response services and community services that are there to enable there to be have we got the right support in evenings and at a weekend, for instance? Can we enhance the single point of access, our SPA service that people can contact for support? So all about, wherever possible, as Chanel has just said, can we provide a community support in the first instance? From a primary care perspective, and again, I think this might connect to the previous conversation with Andrew and Joe, the importance of our vulnerable patients, our shielded patients, that we are able to provide care for them, the importance of our flu campaign going into winter, and the escalated care clinic that we have across both Westminster and our BKC, being there for, again, providing additional and that enhanced level of support. Within our community services then, one of the areas we thought about is do we need additional community beds? We may do, and we have that plan that builds on from our COVID first wave in terms of additional capacity if we need to support us so that we really do meet the needs of our local residents. And then across in our partnership with the local authority, as just discussed, sort of shared here through the care home and discharge to assess and reablement capacity. So those are some of the sort of areas of focus that we have put in. I would want to also bring out that I think our planning work started earlier this year, because it is winter planning and we are used to that. You've seen us come with winter plans before, but with winter, the importance of flu, the need that comes from COVID, and the bit about trying to maintain and support elective flow, so the queries and concerns from before has really sort of demonstrated the importance of us working together as a system, and to be able to flex as time goes on in terms of the drafting of this plan as we have today. So I hope that provides a bit of an overview. Chairman, I don't know if there's anything else you would want, or whether any colleagues from the community or primary care would, whether it's helpful to bring any of this to life.
Thank you, Louise. Does anybody have any questions or comments? Very quiet today.
I think there's a question from Tanya about whether we include blood tests in the diagnostics or not.
Thank you.
Yes, it would.
It would. Okay, so if I could just follow up then. If you're including blood tests and diagnostics, and there have been reports that local blood tests are being deferred, how does that match up with the idea being that patients, again, have to wait a year plus for diagnostics?
So if I may, so I see Andrew has put his hand up, and Andrew, I don't know if this is partly about responding, but I think partly this is about when the same day emergency care is people who are actually otherwise going to be admitted into a hospital as an emergency. So it's about actually being able to, in that situation, can we respond in a different way by organising our care differently? That's what this particular ambition within the hospital is. Andrew, what would you add?
So I was just wondering if some of the anxiety that had generated the question came from the fact that there was a feeling that we were rationalising services or deferring diagnostics that might cause harm to patients. And I just wanted to reassure that that's not the case. In fact, if anything, following the first COVID spike, there has been a lot of pressure to go out and seek and review the level of risk that we might have missed during that period of lockdown when we were going through the surge. So there's a lot more diagnostics going on with regard to blood tests to make sure that we catch up on those number of cancer patients and other things that early patients that we may have missed during the first peak. So there is some prioritization around access to diagnostics, but I don't think it really applies to bloods too much. And certainly if your worry is about causing harm by delay in, say, missing diagnosis, then I think you can be assured there's a lot of focus on making sure that doesn't happen.
That's great to hear. The message is certainly not getting through to patients or the public.
Okay, I really hope that it then isn't coming from experience of the service. I can understand it might be a risk when you're seeing the news and lots of worries about capacity and able to cope. I'd be curious as to whether it's what people are actually experiencing. If that's the case, we maybe need to follow that up.
Sorry, I was talking to myself again. If we move on to item 8, and Andrew Carpenter, I think you're presenting this for final sign-off. Thank you.
Thank you, Councillor Addenbrooke. Yes, that's correct. I'd like to present the dementia plan to the board for final sign-off and approval. The plan was last presented in February, in which only really small cosmetic changes were requested, which have been made, and then, of course, was delayed from May when it had been due to be signed off for obvious reasons. Because of COVID, a debate was had around what was practical, logical, and possible to forecast, what we should therefore include in the plan. So the board will note that there have been some additions made around COVID in the context of course, a number of unknowns about what the full effect of the pandemic might be, both in terms of health and societal impact. So the additions made give examples of adaptations made thus far and point people at where they can get the most up-to-date information, advice and guidance. However, the underpinning values remain very much the same, and of course we'll continue to adapt as necessary and as we learn more about the effect of COVID. And I would of course be more than happy to return, should I be invited to do so, to update the board as and when and as we make those adaptations and learn more. I don't have a lot more to say, I think, because the plan is, apart from those additions, very much the same as was presented in February, where the board received it well and didn't ask for any changes. So on that basis, Chair, with your permission, I'd like to present it for final approval or take any questions.
Thank you, Andrew. Does anybody have any comments or questions? No? Then is everybody happy to approve the plan and sign it off? I will take your silence as agreement. Thank you very much.
Thank you.
Thank you, Andrew. So we will move on to item 9. And Chanel, it's you again with the Better Care Fund programme and an update on the BCF for Q1.
Yes. There are two parts to my presentation. I will do the quarter one quickly. These are very quick presentations. Quarter one is a retrospective presentation for the board's attention. I don't intend to go through the paper in detail. I take it as read. But in brief, this report is for noting, and it covers the period from 1st of April to 30th of June. And due to pandemic, there is no formal reporting on the BCF programme, but the BCF board requires this to be submitted to the Health and Wellbeing Board for our internal governance. The new BCF guidance is not out yet. It is expected soon, though. We have no idea what the new guidance will expect from us or what changes it will require. However, work on the 2021 plan is already taking place, which we will discuss in the next item. This paper shows our total investment, which is around 61.5 million in both boroughs and jointly with health and social care. And as you will remember from previous discussions, we are measured on 4 key performance areas via the BCF integrated programme. We're currently reporting on the 3 of these key targets because the delayed transfers of care is posed due to pandemic. And I'm pleased to inform the board that the BCF plan is on target. I will stop here and take comments and questions, Chair.
Thank you. Does anybody have any comments or questions? No? Seems not, Chanel.
Okay. I can move on to the 2021 BCF plan, which is very much linked into what I've presented so far.
Yes.
So, as directed by NHS England, we're rolling over the 1920 plan to 2021. And because of the pandemic, there wasn't much expectations from us, and the focus was obviously on some bigger issues in NHS. So the BCF programme board has agreed to review it locally in the Borough, jointly with our health partners. We take this year as an opportunity to review all our investment lines individually to make sure that the following pandemic and the changing needs, the plan is still relevant, and that it is delivering the system priorities, and that we're actually getting value for money. So we started the work with LGA, and the review programme in the background is taking place. There's loads of work going on line by line, looking at each scheme that we invest in jointly, and looking at how we can get the best out of our investment. Are we delivering our outcomes? I will update the board in the future meetings on this and present any changes that the board may agree. If we agree that some of the schemes need to change, I can reassure the board that there will not be any money coming out of BCF, but we will be investing the money in alternative schemes. So broadly, the BCF priorities are delivering national policies, of course, maintaining business as usual, alongside delivering the COVID response, and deliver planned and urgent care to those most vulnerable, including shielded patients, and provide support for the care homes. So the plan, the 2021 plan, makes a shared commitment to work collaboratively across health and social care with system partners to make BCF more strategically sensible. And we will ensure that contractual requirements are met. The work aims to enhance the partnership and create a better BCF that will be a vehicle to deliver our local priorities. So there are lots of information on the plan in the paper. I can provide more details if anybody is interested on the line-by-line investments. But I think for now I will pause and happy to take questions or comments.
Thank you. Does anybody have any questions or comments? No? Thank you. So if we move on to item 10, any other business? I know, Chanel, you have something.
Yes, I'll turn on my camera very quickly. We heard Joe briefly talk about the changes to urgent and emergency care and the pilot in Chell West on the changes to 111 and how it will operate. And I felt that this is a change that will affect our residents' care and access to urgent and emergency care. Therefore, I would like this to be on the forward plan for the next agenda item for Health and Wellbeing Board, if the chair and Tim also allows. Would that be acceptable to our health colleagues to come back with a paper for the next board, please? I don't know if Joe is still on the line.
I don't know whether she's still on, but I think that's a very good idea, Chanel.
Okay, thank you. I'm happy to contact Jo if she's not here.
Okay, thank you. And then Nafsika, I think you have something.
Yes, I was a bit surprised that in today's agenda we didn't have the Gordon Hospital. And I think it's very sad to know that at the moment we have no mental health beds in Westminster, and also that there's a proposal to close the Gordon Hospital altogether. And I think that that this is also something that needs to be discussed at the Health and Wellbeing Board soon. And I think it's a real problem for our residents.
Thank you. We'll take that away and come back to you.
Chair, can I remind that the Gordon Hospital closure is on the overview and scrutiny in Westminster agenda on the 20th of October.
Thank you. Does anybody else have any other AOB?
I have one, Chair, if that's possible.
I've got one as well. I'm not sure whether you're going to say the same thing as me.
I think I might. After you, Chair.
Okay. So Councillor Mitchell and I would just like to say a big thank you to Angelica Silverside from Health Watch, who's just stepped down from the board. She has given so much to this board over the years, and her contributions have always been really insightful and always very well received. So if you could please pass on our thanks to her. Thank you. Olivia, was that what you were going to do?
It was, Chair, and to welcome Tanya, who is one of our board members and a local committee member in Kensington and Chelsea, who is taking over the mantle and I must say has already made a flying start. So yes, we'll be delighted to take those thanks back to Angelica.
Thank you very much. So I think that's everything for this meeting. So thank you all for coming today. Stay safe, stay well, and we look forward to seeing you at the next meeting in November, which will be a Westminster meeting. So thank you very much, everyone.
Bye.
Bye.
Bye.